A golden apple from the Department of Medicine residents, and in less than 2 years of being on the faculty, he was identified by our fellows as the Teacher of the Year in the division last year. So he had quite a remarkable impact in the education missions within our system. And he's based on at Grady Hospital. And he'll be talking on an update on lung cancer. And then Srihari Veeraraghavan, who's been on the faculty about 8 years. I lose track as I get older, but he'll correct me. So Srihari is the director of our interstitial lung disease program. He's going to be talking about a very different topic, though, which will be electronic cigarettes. And anyone with teenagers or young adult children know that vaping and whatever else it's called is becoming very, very common and a great concern, particularly for those of us in the pulmonary community, as well as I'm sure in cardiovascular disease and other things. So Srihari also was identified by our fellows within a couple of years of joining the faculty as being our Teacher of the Year in 2011. Last year he was promoted to associate professor. And so this is a really dynamic duo of clinician educators within the division. And I'm very proud to present both of them to you today and look forward to their talks. Munish, start us off.
Thank you so much, Dr. Guido, and thank you to the Department of Medicine for giving me this opportunity to talk on updates on lung cancer screening. This topic has been pretty near and dear to me because for the fact that I did my fellowship from Memorial Sloan Kettering Cancer Center, and 99.9% of my patients were cancer patients. It really took a toll on me when I was doing my fellowship, but I also learned something very fascinating, taking care of very advanced cancer patients, and also I was part of the lung cancer screening program when it was being actually developed at Memorial Sloan Kettering Cancer Center. I was also involved in lung cancer screening program at my first faculty job at Albany Med. So definitely this is a very, very near and dear topic to me. Lung cancer screening has actually become a hot topic in the last 5 years. And that everybody knows is because of the National Lung Cancer Screening Trial. So to begin with, I do not have any conflict of interest with this educational activity, and I do not have any financial relationships to disclose. So I have divided the talk into 3 parts, and each part actually serves as the objective for my talk. I will be discussing about the burden of disease, which is lung cancer, and evidence for the low-dose CT lung cancer screening program. I will be also talking about the review. I'll review the updated lung cancer screening guidelines and discuss about the practical aspects, how the low-dose CT lung cancer screening program is actually implemented. So talking about the burden of disease, it's very surprising that before the turn of the 20th century, lung cancer was one of the very rare malignancies. And now, lung cancer is the 3rd most common cancer in the United States, and it is the #1 cancer which is causing death. So out of all the cancers, 13% of the cancers are lung cancer, and 27% of the cancer-related deaths are due to lung cancer. The American Cancer Society's estimates for 2018 actually say that there will be 234,000 new cases of lung cancer and 154,000 deaths from the lung cancer. And we all know this, that smoking is predominantly the major risk factor for lung cancer, and 85% of the lung cancer is caused by smoking. So men who smoke are 23 times more at risk of lung cancer, and women 13 times more at risk of lung cancer as compared to non-smokers. NIH estimates the total financial burden in 2015 was almost $13.4 billion, and indirect cost of $36 billion from the lost productivity due to early death. The overall 5-year survival rate for lung cancer is very dismal. It's only 17 or 18%. And if you look at the other cancers, other common cancers like colon, it's 65%, breast 89%, and prostate almost 99%. And the reason for this is that we are not doing a very good job. We are only diagnosing 15 to 20% of the lung cancers at an early stage when it actually can be curable. So here is the 2 graphs which I want to point out. It's from the National Cancer Institute SEER data from 2008 to 2014. The top panel actually shows you the incidence of lung cancer on the different age groups. And you can very well see that between the age of 55 to 64, 65 to 74, and 75 to 84, you have the majority of the lung cancer. So 80% of the lung cancers are actually between the age of 55 and 84, and rest 20% are in the different age groups. So that's the high-risk age population. In the lower graph, you see basically the number of new cases and deaths in the United States per 100,000 persons from 1992 to 2015. And you see that the good news is that we are actually diagnosing less. There is actually the incidence of lung cancer is coming down in the last 2 decades, and also the number of deaths from lung cancer is also coming down because of the interventions. This graph actually shows us basically how much is the incidence of lung cancer depending on the stages. So you see that the localized, it's actually 16%. And it's regional, 22%. So localized means it's localized within the lung. So only 16% of the cancer actually is localized, diagnosed as localized. 22% regional, that's spread to the regional lymph nodes. And 57% is diagnosed when it's only advanced. And 5% is unstage. In the lower graph, you see the 5-year survival rates depending on the stage of the lung cancer. So if it is localized, it's 56% 5-year survival. And if it is regional, it's 30%. And if it's distant, it's only mere less than 5%. So you can see that there is absolutely a need for diagnosing lung cancer at an early stage, because we have seen from the data that if you diagnose lung cancer at a localized stage or at a stage 1, you can actually save more lives. So now it becomes very important to have a modality to screen lung cancer, because screening basically is done for diseases where we can pick the disease at an early stage when there are no symptoms and signs, and we can do the intervention to reduce the mortality and the morbidity from that disease. So the next part of my talk is historical perspective and evidence-based approach. So what do we know about evidence in lung cancer screening? So let's see, for the last 35 years, there have been many randomized controlled trials and cohort studies on lung cancer screening. But there are 4 randomized controlled trials which actually stand out till date, which actually looked at the low-dose CT versus no low-dose CT in a randomized controlled fashion and reported the data on both the control arm and the intervention arm. All other trials in the past were done basically for the chest X-ray and the sputum cytology, and we know that it doesn't work. The chest X-ray and the sputum cytology is not a good screening test because it's not sensitive. So we have the Dante trial in 2018. We have the National Lung Cancer Screening Trial, which was published in 2011. We have the Danish Lung Cancer Screening Trial, which is the DLCST in 2012. And then we have the MILD trial from a single-center Italian study from 2012. So out of these 4 trials, only one trial, the National Lung Cancer Screening Trial, was performed in the United States. All the other 3 trials were performed in Europe. They were small trials, and they were not powered enough to actually look for survival. So only the National Lung Cancer Screening Trial till date has been performed in a randomized controlled fashion, which has been able to, which was powered enough to show actually whether there is any survival benefit. And now we have a Nelson trial, which is actually coming up in Europe, which is the first trial, which is going to be reported, which is powered enough for looking at the mortality benefit from Europe. So we do not have any trial from Europe which actually has shown any mortality benefit in lung cancer screening. So coming to this, the landmark trial, which was published in 2011 in New England Journal of Medicine, it looked at actually almost 54,000 participants, 26,000 in the CT group and 26,000 in the approximately in the chest X-ray group. The eligibility criteria was that if you are a current or a former smoker and you have quit within the last 15 years, and you have at least 30 pack years smoking history, and you are between the age 55 and 74, then you are eligible for the low-dose CT screening trial. And you should not have any evidence or any symptoms of lung cancer at the time of being enrollment. So 33 US medical centers were involved in this. It was exclusively an US trial, and all these centers were pretty much tertiary level centers. And it was done between August 2002 to 2004. 3 annual scans were performed, basically the low-dose CT arm and the chest X-ray arm, and these patients were followed up for 5 years. The trial was actually terminated early in 2010 during the interim analysis when they found that there is a clear survival benefit, and the mean follow-up was 6.5 years. the lung cancer mortality reduced by 20% and the all-cause mortality by 6.7% compared to chest X-ray. The number needed to screen, this is very important, was 320 to save one life. And if you look in the perspective, the number needed to screen for mammography to save one breast cancer death is actually 1,339. To prevent one colon cancer death from flexible sigmoidoscopy is actually 817. So this is a pretty decent number for lung cancer screening. Now, definitely National Lung Cancer Screening Trial had certain risks, limitations, and definitely benefit. So the risk which was pointed out by the National Lung Cancer Screening Trial was the problem with overdiagnosis. So overdiagnosis bias is a problem. Basically, you are diagnosing indolent cancers that even if you don't diagnose, it will not cause mortality because they are just indolent. So that was actually 10 to 12% incidence on the modeling studies and the post hoc analysis. Then high false positivity rates. So basically 96.4% in the CT group and 94.5% in the chest X-ray group actually had a false positive scan. So false positive means that if you have on the CT scan, if you have more than 4 millimeter size nodule, you have a positive scan. But when they did further evaluation of that, it didn't turn out to be malignancy. So it was a false positive. So this is a pretty high rate. So I mean to say you have 96% false positive rate in the CT group. So you are doing so many CT scans to diagnose a single lung cancer. Radiation. So that's another problem. But you know that this is a low dose CT, and this is very different from the conventional CT scan. A conventional CT scan uses around 7 to 8 millisievert of radiation. The chest X-ray uses 0.1 millisievert of radiation, and the low dose CT uses around 1.5 millisievert. So it is 5 times less than the conventional CT scan that you do in order for patients for evaluation of lung diseases. So it's a pretty low dose, but still there is a cumulative addition to the radiation. And finally, unnecessary procedures, because you are having so much of false positivity rate, so you will definitely do more investigation, more invasive interventions like biopsy and other procedures, and that will lead to complication. And that rate was almost 1.6%, which was not very high, but still something to be concerned about. Now, the benefits are definitely looking enormous. Now, there are 94 million current and former smokers in the United States, and 8.6 million actually meet the criteria for lung cancer screening as per the NLST criteria. So if you screen all these patients, 8.6 million, you are likely to save 12,250 lives from lung cancer annually at a cost of $81,000 to prevent each death. And this data is published in the Cancer Journal in 2013. Now, this will add $2 billion to the national healthcare expenditure because CMS reimbursement is $300 per low-dose CT scan. So if you multiply 300 with 8.6 million, it will come around $2 billion. Now, this is a problem because you need to have a cost-effective analysis. You need to actually reduce the false positivity rates. So the researchers got together and they decided, let's find out a way that we can actually nail down the highest risk group where a screening can be applied. Now, the National Lung Cancer Screening Trial looked at the age, the smoking status, and the cumulative exposure of smoking, that is the PAC years. But they actually excluded all of the risk factors of lung cancer like COPD, family history of lung cancer, personal history of an extrapulmonary cancer, pulmonary fibrosis, radiation exposure. So all those risk factors were actually excluded from the NLST criteria. So what these researchers did in this publication, which was targeting the low-dose CT screening according to the risk of lung cancer death, they actually developed a PLCO M2012 risk prediction model. Now, this model was actually modified from the PLCO trial, which is the famous prostate cancer, lung cancer, colon cancer, and the ovarian cancer screening trial, which was published in 1990s, and it was actually a failed trial for the lung cancer screening. They took up that trial and used the data and made a prediction model using the age criteria, smoking status, gender, family history, COPD, obesity, and educational background. So they used this modified, and they validated this model, and they used it on the NLST cohort. So when they used this in the NLST cohort, they divided the NLST population into 5 quartiles on the basis of risk. The highest risk was one which has the risk prediction of more than 1.51%. So they said that if you actually target the patients who have the highest risk quartile, on the highest risk quartile, which more than 1.51%, you can actually limit your screening in the NLST cohort to 60% of the population, but still are able to actually detect 88% of the CT preventable lung cancer deaths. And you are able to reduce the number needed to screen from 320 to 161. Now, just be very mindful, this is only a modeling approach. This is not a randomized controlled trial. But this is one way to look that if you want to actually limit your patient population and reduce the false positivity rate, then you can actually use this. So my next part of the talk is guidelines. Now, this is where I will confuse you a little bit, and because guidelines are all over the place when it comes to different professional societies. But we'll try to actually make a sense in the third part when we talk about the practical tips of how to implement lung cancer screening. So CMS, the Center for Medicaid and Medicare Services, in 2015 came up with a national coverage determination for the first time. So the trial was published in 2011. It took 4 years of intense discussions with different professional societies to come up with a final criteria, which will be a national coverage determination. So they decided the age group of 55 to 77, asymptomatic, with no signs and symptoms of lung cancer. You have to be 30 pack years, that is 1 pack a day for 30 years, and you should be a current smoker or a former smoker, quit within the last 15 years. If you fulfill this criteria, then you are qualified as per the CMS for the low-dose CT lung cancer screening program. Now, you have to have a written order for the low-dose CT lung cancer screening program, and prior to that, the CMS mandates, I repeat again, the CMS mandates that you have to have a shared decision-making visit and a smoking cessation counseling visit, and note that in your medical records. You can use the codes which are mentioned here, because a lot of times we are looking for the codes how to actually order the low-dose CT scan, and my fellows always ask us in the clinic. So these are the codes which can be used to actually order the low-dose CT scan and for the different visits. So United States Preventive Service Task Force actually gave grade B recommendations in 2014 for the lung cancer screening. Their criteria is slightly different. So they use the age criteria of 55 to 80. And they did that on the basis of some modeling studies, and they said that actually the benefit ranges actually up to the age of 80. But the CMS says, no, we're going to do only till 77, because the last age group was 74, and they got 3 annual scans. So 74 plus 3, 77. So we're going to actually do 77. But the U.S. Public Service Task Force said that no, because we did the modeling studies on different, on all the data, and we say 80 is probably the ideal one. They still had 30 pack year smoking history, and you still have to be a current smoker or a former smoker, quit within the last 15 years. And you should not be having any symptoms of lung cancer. And the screening should be performed only if you do not have any significant comorbidities. So that should not limit your life expectancy, and you should be able to, and you are willing to actually have curative intent treatment. Otherwise, there's no point of doing a screening if you're not actually eligible for that. Then we also had the National Comprehensive Cancer Network 2018 guidelines. So National Comprehensive Cancer Network actually gives guidelines every year. They update them. They recently updated in March of 2018. Their guidelines are also pretty much similar to the NLST criteria. They divide them into the high-risk status, moderate risk, and low risk. And they say that patients should be screened in the high-risk status, and their high-risk status is actually exactly similar to the NLST eligibility criteria. So age 55 to 74, 30 pack years, smoking cessation within the last 15 years. But they also add the NCCN Group 2, which is basically a criteria which actually they are stressing on, because we have seen a lot of lung cancer in patients between 50 and 54 age group who are actually not 30 pack years but more than 20 pack years, and they have an additional risk factor. So the additional risk factor could be you have COPD, you have pulmonary fibrosis, you have exposure to occupational carcinogens. So all those things actually form the NCCN Group 2. So they are actually forcing the CMS and actually asking them to actually include that in also the ambit of lung cancer screening. And finally, we have the chest guidelines, which got published in January of this year. This is from the American College of Chest Physicians, and they also are going along with the CMS criteria. So age 55 to 77, smoking 30 pack years or more than that, and you should have quit smoking either within the 15 years or you're a current smoker, and you should not have any symptoms of lung cancer. And finally, they also say that you can offer low-dose CT cancer screening if your patient does not meet the age and smoking criteria above, but has the PLCO-M 2012 validated model risk more than 1.51%, which we showed you in the recent trial, which they did. So they do say that if your risk prediction is more than 1.5% on this model, and you do not fulfill the age and smoking criteria, you can still actually offer screening. But once again, the CMS does not approve it. So if your patient is a Medicare, Medicaid patient, he is not going to get approved for the CAT scan. And they also say that no screening if the patient has significant comorbidities. So the next part of my talk is actually how you implement this thing in the real life practice. So putting prevention to practice. So I'm going to actually give you this perspective with a case. So we have Mr. Z, who is a 68-year-old man with a past medical history of hypertension, who is an active smoker with 1 pack per day for 40 years. So he has 40 pack years. Recently, his cousin, who is also a smoker, was diagnosed with lung cancer, and Mr. Z is very concerned given he himself has a long-standing history of smoking. He comes for a routine PCP visit today and inquires about the lung cancer screening as he heard about this in a local newspaper. So there are 3 important questions here. Is Mr. Z eligible for the low-dose CT? That's what you have to ask. In which scenario Mr. Z will not be eligible or will become ineligible for the low-dose CT screening? And finally, what are the steps to implement this program? So looking at the first question, he satisfies the age group, 55 to 77, smoking status, he's a current smoker, and he actually has enough pack years, more than or equal to 30 pack years. Now, Mr. Z should not have any symptoms of lung cancer, because if he has symptoms of lung cancer like weight loss or hemoptysis, he will not be eligible for the low-dose CT. Then he should actually get an actual conventional CT scan, high-resolution CT scan. He should not have significant comorbidities because that will actually preclude him from the curative intent treatment. And he should also not have poor history of compliance. He should accept the shared decision making. If he does not accept that, then he is not eligible to the low-dose CT screening. So all these questions have to be asked from the patient before you refer to the lung cancer screening program. So this is the algorithm. You get a patient in the clinic. You look at the eligibility criteria. If the patient is eligible as per the CMS criteria, then you basically refer the patient to the lung cancer screening. And the lung cancer screening program will do the first shared decision making and smoking cessation counseling visit. It has to be documented as per the CMS. So you have a face-to-face meeting with a nurse navigator or a physician provider. You basically review the eligibility criteria. You discuss the risk, that is the false positive rates and the diagnosis and the radiation exposure, everything with the patient, and you make a shared decision, okay, to go into the program. You discussed about the compliance. You discussed that the screening is not going to prevent lung cancer. It has only shown to reduce the mortality. So still he has to stop smoking. So smoking cessation counseling is very important at that visit. And then you can also use decision aids, which are available at the National Cancer Institute websites, which you can use with your patients to make the decision on whether they are eligible for low-dose CT scan. And if the patient declines, the relationship is terminated. If the patient agrees, you order the low-dose CT scan, and then you follow up accordingly. So there are 2 types of low-dose CT lung cancer screening programs prevalent in the United States at this time. There is a decentralized program, and there are centralized programs. So the decentralized programs are the most common one, but they are the traditional programs where any physician and non-physician provider determines the eligibility, does the shared decision making and the smoking cessation counseling, orders a low-dose CT scan, follows up the low-dose CT scan, and does the needful. In the centralized lung cancer screening program, you as a physician and non-physician provider actually determine the eligibility and refer the patient to the lung cancer screening program. They themselves actually determine the eligibility again and then call the patient for the shared decision making and smoking cessation counseling visit. And then basically they do the needful for the lung cancer screening. I just want to point out lung RADS. A lot of you must be seeing this on the reporting of the low-dose CT scans. This is a method of reporting and management for the low-dose CT lung cancer screening program developed by actually the American College of Radiology. And it actually includes categories. So you have category 1 to 5 and also an S category. So category 1 to 5, out of this category 3, 4, and 5 are the positive scans, which basically needs an immediate intervention. And category 1 and 2 usually require a follow-up annual CT scan because they are negative scans. Category S actually means that you find something which is extra pulmonary incidental finding, like a thyroid mass or coronary artery calcification or aneurysm, and then you have to basically do a clinical follow-up, immediate clinical follow-up of that. Now, lung RADS has shown to improve the detection of lung cancer and decrease the false positive rate from 1 in 10 screened individuals from actually 1 in 4 in the NLST. So it actually has improved the reduction, it has led to reduction in the false positive rate and also improved the incidence of detection of the lung cancer. So what are the challenges for the low-dose CT program? So definitely eligibility and the need for shared decision-making is a challenge, because you will see sometimes that patients get low-dose CT scans even though they're not eligible. Shared decision-making has to be there, and there is also variation in the delivery, interpretation, and reporting of the low-dose CT scans. There is also concern about the variation in the nodule management and the follow-up. Now, there are all kinds of guidelines available. There is a Fleshner guidelines available for follow-up. There is the NCCN guidelines available for follow-up. There is the CHEST guidelines for follow-up of nodules. So there is a lot of confusion there. And they're definitely managing the incidental findings. And most importantly, the CMS also requires you to actually include each and every low-dose CT scan into a CMS-approved registry. So you cannot actually just do a low-dose CT scan and just get away, because you have to document all these patients into a registry. And also we have to effectively implement the smoking cessation program, because that's basically the bedrock of reducing the lung cancer incidence. And also look at the safe and quality outcomes. And finally, I'm going to just touch base on a policy statement which was released on the high quality lung cancer screening program. Anybody who's very interested in that could actually read this policy statement published by American College of Chest Physicians in Chest Journal. This was in 2015. They give you a very detailed analysis and recommendations how you can actually implement a high quality lung cancer screening program in your institution. And there are 9 components, and each component has many recommendations associated with that. So future directions, I think we still need to refine the age group. We know that 55 to 77 is the standard now as per the CMS, but we also know that NCCN is pushing for group 2, that is age 50 to 54, because those patients are also at risk of lung cancer, especially when they have additional risk factors besides smoking. We're also looking at what is the ideal frequency. Is it annual? Is it biannual? So the NELSL trial, which I just told you is being done in Europe, is actually looking at a different frequency. They are actually doing at a different frequency protocol. They're doing the baseline scans, then at 2 years, and then at 4 years. So they have a different frequency of low-dose lung cancer screening. So we'll see. It will be interesting to see what the results are. And we also have to make sure that we actually value the other additional factors. Age and smoking status is an important risk factor for lung cancer, but there are other risk factors like COPD, pulmonary fibrosis, exposure to occupational carcinogens, which are also important in causing lung cancer. Once again, NCCN Group 2, as I mentioned, we need to look into this group, and a lot of professional societies are now pushing CMS to include this in the ambit of lung cancer screening. More research is needed and is being done to actually find biomarkers. So if you have a positive biomarker, you actually direct your lung cancer screening in those patients so that you actually reduce the false positive rate and find the highest group which actually benefits from this modality. And finally, we need to also address the potential harms of radiation. And we also need to assess the cost-effective analysis, because any screening test to be effective has to be cost-effective. So take-home points. An annual low-dose CT scan is the only screening tool which has shown to reduce mortality in lung cancer, especially in the high-risk group. Screening should be viewed as an adjunct to tobacco smoking cessation. So please always talk to your patient about the smoking cessation counseling when you talk about the low-dose CT, because that's the only very important preventable cause for basically lung cancer. Lung cancer screening should not be performed if your patient has significant comorbidities or if the patient is non-compliant, because you're just opening a Pandora box of nodules. Shared decision-making visit and smoking cessation counseling visit is mandatory and must be recorded in your medical records prior to the order. Centralized screening programs and multidisciplinary approach has actually shown to be more effective than decentralized programs and have shown to have better outcomes with the lung cancer screening. Thank you so much.
Thank you, Munish. Munish great talk with a lot of data. So as an antidote, I'm going to give something with no data because it's not much, right? So don't worry about it. Right? So we're going to talk maybe next 20, 25 minutes on electronic cigarettes. No conflict of interest. I don't own a vape shop. So we're going to talk about prevalence of e-cigarette use, human health effects, whatever we know, and what's the role in smoking cessation. This is a typical scenario in the clinic, especially in the pulmonary clinic. We see patients show up and wants to talk about using e-cigarettes. This is a 52-year-old woman, long-standing history of smoking, had multiple attempts at quitting, had tried all the patches, the gums, Wellbutrin, not able to tolerate Chantix, and then is asking you, wants to try e-cigarettes and wants to know what your opinion is, right? The problem is, most of us don't know what to do in this situation. So what are e-cigarettes? E-cigarettes are, can look like cigarettes and need not be cigarettes, but electronic cigarettes usually has a battery in it. Usually it's a lithium battery. Has one end is the mouthpiece. There's a heating element, and next to the heating element is a cartridge where they have some liquid, which usually contains nicotine in solution. And anytime it's triggered either by a switch or sometimes by inhalation where it vaporizes the liquid, and then the patient is able to smoke whatever the solution is in there. It doesn't have to look like a cigarette. It can look like a pipe, cigar, a whole bunch of other things which are available. There's even e-hookah available now, right? So what are e-cigarettes? They're essentially electronic nicotine delivery systems called as ENDS. That's what usual exact terminology is. It heats a liquid containing nicotine, but there are e-cigarettes which doesn't have nicotine at all. Usually has a solvent, and the solvent is commonly propylene glycol, and sometimes has vegetable glycerin in it, and then it has a whole bunch of flavorings, which is the most difficult part. So when you heat up a paper cigarettes, there's probably at least around 7,000 chemicals in there, maybe 200, 300 known carcinogens of significant event. Whereas in e-cigarettes, it's very difficult to know. We don't know because it's not very well studied. Almost all of them have nicotine if they are nicotine cigarettes. They usually have some ultrafine particles. They have some diacetyl, a majority of them in flavoring, which we'll come to in a minute. There's some acrolein, which is associated with cancers. There's a lot of volatile organic compounds associated as well. And a lot of these e-cigarettes have some kind of heavy metals in small quantities. The problem with e-cigarettes is there's no quality control. There's majority of them, more than 90-95% of them, is produced in a single area in China out of some large companies and also some small companies which just make out of shed. There's no labeling. You have no idea what is in there. Usually you may label about some nicotine percentage, how much it's a 10% liquid, 5% liquid, something like that, and then something about flavor, but you have no idea what chemicals are in there. There are at least 7,000 different flavors available in the U.S. There's no clear standard about amount of smoke inhalation because, like Munish talked about, in this pack years is very important, whereas here you have no idea when you're smoking what is the equivalent in terms of pack years. There's a lot of things called mod. If you don't think there's a mod cigarette, it's modified, where the user just changes the settings in there, and they do a rejig in there so that they can get more smoke inhalation as opposed to standard you buy out of the shop. There is something called sub-ohm, where they change the resistance so that you have a little lower resistance and you end up getting more smoke. So there's a whole bunch of industry out of there which people do. So we don't know exactly if two people are smoking e-cigarettes what the equivalence is. And there's a lot of essentially now case reports coming of e-cigarette related problems because we don't have a large set of series. So you may remember this case of microwave popcorn related problem in the lung is in plant workers. They diagnosed bronchiolitis obliterans several years ago who were exposed to all the flavorings in the popcorn. And then there was a patient in Colorado who took 2 bags of popcorn every single day for more than 10 years. And then he used to open up the butter popcorn, smell it, and then eat it every day. And then it turned out he got bronchiolitis obliterans. And then he sued, and then he got nearly $7 million. It was in the news like several years ago. So what was the chemical agent in there was diacetyl, which was the cause of the bronchiolitis obliterans. So that was inhalation from a popcorn bag. Now, in Howard, they looked at it a couple of years ago, what are the chemicals in there, and about 50 flavors tested. Close to 40 of them had at least, diacetyl in there. So we have no idea whether how these chemicals are going to affect the lung and whether any more symptoms are going to, patients are going to end up with these symptoms. There's a whole bunch of other case reports of the thing. There's lipoid pneumonia because you got all these things have some kind of oily based material for solution, and then has been associated with lipoid pneumonia. There's hypersensitivity pneumonitis associated with this because based on whatever the chemicals they use. Eosinophilic pneumonitis has been associated. And more concerning, this acute lung injury has been reported both with regular e-cigarettes and then e-cigarettes with vaping with cannabis oil, because they can add whatever you want, not just nicotine solution, but you can add everything else you want in there because a lot of it is basically done by the people at home, and they can add whatever they want. And there's all associated with acute lung injuries. So what else didn't happen? This is the good old FEMA actually published a report last year about fires in electronic cigarettes. And a lot of these are lithium-ion batteries, and there's increased risk for fire whenever they are damaged. So there's been a lot of, every few weeks you'll see a case report somewhere in the news saying somebody got burnt because of the electronic cigarette. But one of the important things is a whole bunch, but then you say the shape and construction of electronic cigarettes can make them more likely than other products with lithium-ion batteries behave like flaming rockets when a battery fails. So I don't know, but it may not be a good idea to have a flaming rocket right up to your face, So what about other problems? There's a lot of ingestion. There's at least one case report associated with death in a young child with ingestion of these liquids. A lot of these comes as liquid, and instead of buying from the shop, they buy the liquid, and then they can refill it so that they don't have to buy the cartridge. And then it's associated with ingestion. So this is only up to 2014, and the number of e-cigarette users significantly increased in the last 2-3 years. But there has been a significant increase in ingestion of these liquid. It's mostly among kids 0 to 5 years, since they're left alone. It also has a lot of flavoring with that, and a lot of colorful stuff in there, and so there's increased risk for kids to swallow. And also it's mainly ingestion, occasionally inhalation. One of the other things to think about is skin exposure. Nicotine can be absorbed, through the skin, and then anytime when they fill and they're not careful and they spill on the skin, you can have both local and systemic side effects with nicotine ingestion. So is it really a problem? Well, the question is, so all these are there, but is it a really problem? In the U.S., it's more common in the youth than in adults, and by 2014, it has surpassed conventional cigarette use. So in kids, youth up to age 25, electronic cigarette use is more common than regular conventional cigarette use. And past 30-day use of e-cigarette in middle school is about 5%, in high school is about 16%, that's 2015, and that's about 1 in 6. Young adults, again, is about 14, 15%, and older adults, it's much lower. So it's basically a fad which is much more common in kids. And the e-cigarette market is going up. 2017 and 18 are estimated is at least $3.64 billion, and the expectation is it's much higher than this. It doesn't even look like a cigarette, right? So I was walking in the airport last week where they sell, duty-free alcohol and cigarettes. And this is what they sell. It's majority of this. This is an e-cigarette, and looks fancy. Looks like maybe a lipstick or something. That's what it looks like, right? Sometimes one of them is an inhaler for lung disease. The other one causes lung disease. So there's various different ways in which you can. And then this is the most common one. It's called Juul, and they call it juuling, instead of vaping for kids. And this is an e-cigarette. It looks like an USB drive, and these are different flavors which comes with it in the starter pack. And you can recharge it. You get this little USB charge, and kids are using this in school all the time. And this is the most common e-cigarette used in the United States, especially in kids. You can see this Juul is actually was started by 2 Stanford graduates as a startup, right? And market share is about 30% of a third of the U.S. market, and it's grown like 700%, in the last year. It's a tremendous amount. But if you skip that, and you can see all the other ones, these are all the usual players in terms of tobacco industry. There's a British American Tobacco, Altria, which used to be Philip Morris, Imperial Tobacco. So all the regular tobacco companies were all moving from regular cigarettes to conventional cigarettes, and they were probably 80-90% of the market is based on them. And it shows up. This is from New York Times, and you see this is April this month. This month is December of 2017, January of 2018. So all of these is within the last 3-4 months in New York Times alone. And schools are having a big problem, especially with Juul, because it looks like an e-cigarette, and the teacher turns around, they take a hit, and there's smoke everywhere, and they can't find out who it is. Because, so it is a big problem, especially in kids. But what about regulation? As you can see in green, in the U.S., there's not much regulation, hardly anything there. But it's banned in a lot of South American countries, in Mexico, to some extent in China and Australia. But Russia, India and U.S. are all, there is no regulation for these. The FDA said that they're going to regulate e-cigarettes like they would regulate conventional cigarettes. This all started somewhere 2 years ago in 2016. They said all products that meet the statutory definition of tobacco product to be subject to FDA's tobacco authority, like they would do. So they brought in ENDS, or electronic nicotine delivery systems, and including cigars, hookah, and everything into that final comment rule. And then they decided that they would need a pre-market application, which means that for every single one of these e-cigarettes and any of those refills they have to have an application with the FDA, and the applicants must prove scientific data to demonstrate that the new tobacco product is beneficial to the population as a whole, including users and non-users. This was done in 2016, and they gave a 2 years time for all these people to comply. So by this year, August 2018, they were supposed to comply and get all the paperwork in. But sometimes, a few months ago, they changed the rule, and they said they're going to have a comprehensive look of both cigarettes and electronic cigarettes, and looking towards decreasing nicotine to decrease addiction in all of them. And since they pushed the compliance date to August 2022, so it's not going to come for another 4 or 5 years. So, regulation-wise, there's not much happening. But in terms of smoking cessation, which is what our patients want, is it useful? There are several very small trials. There's no big trials. If you go to clinicaltrials.gov and look for electronic cigarettes, there's probably about 30 to 40 current open trials available in the U.S., and majority of them are not even looking at this problem. There's no high-grade randomized trials. And the reason for the low grade is duration of follow-up is very minimal. As you know, in smoking cessation, people always stop and start and stop and start. So unless you follow them up for a longer period of time, it's not going to be much useful. There's no biochemical variation where you check for carbon monoxide in the breath analysis or urine nicotine or cocaine. And there's no continuous follow-up. They see them once after 6 months or so. For a variety of these reasons, then most of the studies was there are poor quality studies. This is one study, published in 2018 by Thomas Eisenberg. He's a really big name in tobacco industry or tobacco assessment in the academic industry. The reason why I want to present this is it was an 18-patient study followed up for 6 weeks. So even now, whatever these studies will come out are very small pilot studies and very little data. Right? And then the smokers were asked to switch from cigarettes to electronic cigarettes, and in the end product was in 6 weeks, they felt switching to e-cigarettes might reduce some types of harm from smoking. It's essentially very minimal improvement. There's another studies came out this year, but there's a cross-sectional study done in 2014, and more than 12,000 subjects in EU, without UK, the whole of continental Europe. They felt that nicotine e-cigarette use was associated with lower odds of being a former smoker, which means that if they were using e-cigarettes, they were not quitting. So the sense of this study was we felt this was basically a cross-sectional analysis. They were collecting a lot of data, and then this was just a study which was done after. This was not a direct study with regard to e-cigarettes, but looked at patients who were smokers and had e-cigarettes and see whether they were former smokers or not. So people with e-cigarette use were not quitting. So that was the essence of this. There are very few randomized control trials. One of them published in Lancet in 2013. They assessed 650 patients. They gave them nicotine e-cigarettes or nicotine patches or placebo e-cigarettes. And then they looked at 6 months and see if there's verified abstinence. There was some improvement with e-cigarettes. There was 7% people were abstinent if they were given e-cigarettes, 6% with patches, and 4% with placebo e-cigarettes. So essentially, quit rate, there was slightly better with electronic cigarettes, but this study was not powered because they expected a lot more patients to quit, and because there were only very little amount of patients who quit, it was not powered to say whether there was, benefit or not. So there's always a Cochrane review. They start off with a whole bunch of studies. This is actually a second Cochrane review. There was one in 2013, which also did not find any good studies. But they looked at 27 studies. 3 of them are randomized controlled, including the last one, and 24 cohort studies. Only 2 studies out of all that were considered appropriate. And based on those 2 studies, they said e-cigarettes help smokers to stop smoking in the long term compared to placebo. Essentially, that's what it is. But then the confidence in the result was labeled as low because of all the things we talked about. So if you don't have good data, what's the expert opinion? There's a position statement in 2014 by international respiratory societies, including American Thoracic Society and European Respiratory Societies. So at that time, they said, as a precaution, electronic nicotine delivery should be restricted or banned until more information is available. And if they are allowed, they should be closely regulated as medicines or tobacco products. But all of this was based on very minimal data, and the opinion was it may not be a good idea. So that's from the U.S. and a whole bunch of them. But in the U.K., they have a different take. In April 2016, the Royal College of Physicians had a paper on nicotine without smoke and tobacco harm reduction. So they feel, again, with the minimal amount of data, that e-cigarettes appear to be an effective aid in quitting smoking. Their estimate is that tobacco, compared to regular conventional cigarettes, the e-cigarettes probably have 5% of harm. I don't know where they got that number from, but that's their consensus opinion. And then in the interest of public health, it's important to promote the use of e-cigarettes, nicotine replacement therapies, and other non-tobacco nicotine products. So this is what the feeling is. And the NHS does not supply e-cigarettes yet, but there's a push in UK towards more e-cigarette use. So essentially, what's in conclusion, there's very limited data on whether e-cigarettes help in terms of quitting smoking or not. In terms of expert opinion, it probably helps people who are already smoking because there's significant risk reduction compared to conventional cigarettes. The problem is there's a whole lot of additives in addition to the nicotine, which are the flavorings, and maybe a lot of side effects related to that. We have no idea. But the biggest concern for all of this is to initiating kids into smoking, because majority of the e-cigarettes are sold to younger adults, and with all the flavors and the way in which they look, it's all marketed towards young adults, and that's the main complaint. And that's where I'm going to end. Thank you.
If I could get both the speakers to come up and see. Are there any questions from the audience at this time? Maybe I'll start by, I'll just quick ask a question to Jonathan again. And to be devil's advocate, if my kids were here, they'd be surprised because I told them if they started smoking as teenagers, they had to become emancipated minors and move out and fend for themselves. But in 1900, there was a lot of tobacco use in the United States, but it was all plug and chew tobacco, and lung cancer was virtually unheard of. So it really was the advent of smoking that created the epidemic that Munish talked about. So to play devil's advocate, if people are going to become addicted to nicotine, and again, this is devil's advocate, and would it be better to identify nicotine delivery systems that at least don't have this enormously high risk of lung cancer, assuming e-cigarettes don't cause lung cancer? I don't know what you think.
I agree. I think
use the mic. Yeah.
The risk for use of e-cigarette developing all the problems in the conventional cigarette is much less. The concern is whether they go from e-cigarette to a regular cigarette, and that's the only concern. And then if you think that they're going to use just plain e-cigarettes, and maybe they may is significantly less harm compared to regular cigarettes.
Yeah, thank you very much. Question about CT lung cancer screening. We are ordering a lot of these in clinic. We don't necessarily document shared decision-making by any kind of format like you've outlined, and the registry I don't think is being kept. I was curious to know if our colleagues in radiology are taking any of that responsibility.
Yeah, so you're right. This is quite rampant across the board. So as per the CMS recommendations from 2015, we are supposed to document in our medical records if we are specifically ordering a low-dose CT for lung cancer screening. We have to document that we have made a shared decision with the patient after discussing the risk and benefits of the lung cancer screening, and patient has accepted the program. And we need to actually include each and every patient data in the CMS approved registry. Now, that's a requirement. In the beginning, when the CMS actually gave these recommendations, we did not have any ACR, which is the American College of Radiology designated registry, but now we have. It costs money because you have to get that registry from the ACR. Now, a lot of big institutions have their own registry, and they are actually moving that to a CMS-approved registry, the data. It's a requirement, but it is not being fulfilled actually across the board. You're right.
I had one quick question. Thank you for the talk about the lung cancer screening. So I think I understand the number needed to screen is around the 300s and then maybe drops to around the mid-100s. I was trying to understand the number needed to harm for actual screening. So what's the balance? Because I think I was calculating it was in the 60s, but I don't know if that's...
So I mean to say there is no potential, I mean the harm that I pointed out were mostly from the false positive cases that actually went on to have extra procedures which would not have been done if they were not part of the screening. And that was 1.6% in the low-dose CT group. There was not a single, I don't think so, if I remember correctly the data, there was no death from the intervention leading to a complication in a person who had a false positive CT scan. So I don't remember off my head what was actually the number needed to harm, but the trial also had some limitation, which was one important limitation was that the patient population in NLST was pretty healthy. So you have to understand that only like 10% of those patients were actually in the age group of like 65 and 74. So a lot of these patients were much younger and much more healthier, actually. So that's another issue which comes up with the NLST, that whether it is able to, I mean to say, replicate in the population, real-life population.
Questions from the outside?
We have one question from Grady. What percentage of resections are positive after a positive scan result?
Sorry, repeat again?
True positives after scans. What percentage of lung resections are positive for cancer after a
Yeah, so it was, I think, around, the detection rate was around 1% for the true cancers. So it was pretty dismal. That's why they are trying to actually find more ways to actually restrict the screening to the highest risk group. And that's why this PLCOM 2012 model came into light in 2013 study. We still do not have a randomized controlled trial which could prove that if you include other additional risk factors, it will probably reduce the number of false positive. And we are waiting for the Nelson trial, which is the European trial, a big trial which is being conducted, which is also including other additional risk factors. So we'll probably come to know in the near future about that.
But in terms of the question, sounds like it also related to how many benign nodules get removed surgically, and that number is relatively low, but the study, I don't know that addressed that.
No, I don't think so. It was
it really comes down to
it
comes down to the post-CT workup, which you alluded to,
Yes.
is very heterogeneous depending on where you
Absolutely.
present. So, all right, well, thank you, Munish and Srihari, for your presentation, and everyone enjoy the rest of your day. Thank you.
Thank you so much.